Hi, everyone. Welcome to CAEP Grand Grounds. We're very excited for you to join us. Today, we're going to be discussing diagnostic reasoning and system factors in the emergency department. We're going to be taking a quality improvement and patient safety lens and some considerations when we look at diagnostic reasoning. So our learning objectives today include identifying common system factors affecting diagnostic reasoning. We're going to be talking about the top 5 diagnostic issues in emergency medicine. And we want to talk about the systems thinking approach to improve diagnostic reasoning processes. So my name is Ahmed Taher. I am a quality lead of the emergency department at Mackenzie Health. I work at UHN Emergency Department. I'm the editor-in-chief of HICCUPS, which is a free open access medical education website that talks about many interesting things. We are lucky to have a whole slew of very experienced speakers, starting with Dr. Shirley Lee with the CMPA. Previously, she's been the Director of Education at the Emergency Department or the Schwartz-Reisman Emergency Department, and the SEMI Program Director, and she has many national and international recognitions. We have Dr. Sandra Monteiro, who's a Faculty of Health Sciences Merit Scientist appointed to the Department of Medicine and also the Center of Simulation-Based Learning as the Director of Scholarship. Her international work currently focuses on investigating theoretical models of cognitive processes. Very excited to have her here with us today. We have Dr. Lucas Chartier, who's the Medical Director of Quality and Safety at the University Health Network. He's also the Founding Director of Quality and Innovation of the Emergency Department and currently serves as the Deputy Medical Director with extensive local and national leadership positions in quality and safety. Finally, we have Dr. Sean Manju, who is Quality and Safety Lead at the St. Joseph's Healthcare Center Emergency Department in Hamilton. He's an assistant professor with the Department of Medicine at McMaster University and founder of Lyft Healthcare Data Analytics Company. We're very grateful to have everyone on board on our speakers panel. So here are our disclosures. So we're going to jump right in. When we talk about diagnostic or clinical reasoning, we're talking about a process that involves the clinician arriving at a diagnosis, treatment, or therapeutic plan. And classically, the focus has been really on the clinician's cognitive process. What actions are they taking in terms of historical points that they are collecting? What physical exam maneuvers are they choosing? And what investigations they're carrying out to be able to come up with a diagnostic plan and management plan. And really, a lot of this has been based on the mental representations that they're doing, that they're making to be able to go through this process. A lot of the theory that has been brought forth historically has focused on the clinician's cognitive processes. One salient theory is the dual process theory, which you may have heard of, including system 1 thinking and system 2 thinking, one being very rapid, implicit, non-analytic, and one being more time-consuming, analytic, and actually having a problem-solving approach. Thought to be a simplistic point of view that these systems may be there, but also interact with each other, and you can go back in between them and calibrate them to come up with a reasoning approach to calibrate to get to your diagnosis. And more recently, that clinicians also are thought to have this intuitive, non-analytic reasoning as they become experts to be able to generate a few high-yield diagnostic hypotheses during the diagnostic encounter itself. And so these were just examples of some of the theories behind the cognitive reasoning literature. But really, a lot of them and a more recent work has really focused on the clinician in isolation of what is happening around them, what is happening along the clinician's cognitive processes to derive at the diagnosis. However, when we show up to the emergency department and it is quite busy, and you can reflect on the fact that your thinking, your reasoning is affected by many different things, both external and internal. And so the cognitive processes themselves do not happen in a vacuum, but there are other things to consider. And some of these factors are both individual and a system level. Some of the individual work has focused on bias and focused on different cognitive biases that clinicians have that can lead to specific cognitive errors. And then once a clinician is able to be aware of these biases, there are certain things that you can see on the screen on the right that they can do to help their own cognitive reasoning process to basically try to mitigate these biases. However, I argue that it is not only an individual cognitive process, but showing up to your shift, a clinician has many different factors affecting them externally as well, from the different workload that they're having, fatigue, the constant interruptions, many things that can create suboptimal cognitive processes and may lead to diagnostic errors as well. The other thing to consider is where the clinician is practicing. So if you're practicing at a tertiary care center or a community site or a rural site or different places, the way that you are making diagnostic decisions may differ. When we reflect on seeing, let's say, a young female, right lower quadrant pain, equivocal exam, really many things can affect the way that the diagnostic reasoning process can occur, from what time the patient presents, how busy the department, access to medical imaging, consultant access, et cetera, et cetera. If you practice in more than one context, will your decision-making differ? Will your approach differ? And this is when we start to talk about context. And so the context that you're practicing in is the scaffold or substrate that the clinical encounter operates in. It can influence the way that different clinicians are operating in and or viewing the same clinical encounter itself. And this is where we can start to draw similarities to the quality improvement in patient safety literature, where really the focus on medical error has taken a big jump from really focusing on the clinician, the individual clinician, and what they may have done as being wrong or error, and really starting to focus on the system in which they operate that had led them to this error. And what we're saying is that you can start to view the same or use the same lens when looking at cognitive reasoning, and that the clinician does not operate in a vacuum, but they operate in a complex adaptive system. And if you've come across complex adaptive systems, really the thing to take away is that there are a lot of components to the system and many components are interrelated. So when you change one part of the system, you can alter other parts, including a clinician's diagnostic reasoning process. And so some of the earlier work focusing on the cognitive processes or cognitive reasoning put forth specific recommendations to educate the clinician to be able to help mitigate cognitive reasoning process or diagnostic reasoning processes. And some recommendations were actually placed more so on the system level, I think, in terms of things around the workplace. How do you structure data acquisition? How do you create slowing down strategies? And how do you build supportive environments for clinicians to be able to have a better diagnostic reasoning process? They also talked about using forcing functions. And from the quality improvement realm, using forcing functions is a very powerful tool if used in the correct manner to be along the hierarchy of effectiveness, and things like clinician or clinical prediction rules, cognitive forcing strategies, checklists, and hard stops. However, a lot of these recommendations were still made focusing on the individual clinicians' thinking themselves. But when we start to look at system factors, we really start to reflect on the entire patient journey in the emergency department. If you look at the clinical encounter itself, where was the patient seen? When were they seen? How were they seen? Is it virtual? Is it in person? Are they in a hallway bed? Are they in their own private room that you're assessing them? Many factors can affect the diagnostic reasoning process. And so these are factors that we need to start to think about when wanting to optimize these processes. You can also look at the patient journey from triage till disposition planning, not just at the end of the emergency visit, but beyond what exists in the community, and looking at all of these factors from the investigations that are ordered, how they're ordered, when they're ordered, how they're completed, and so on and so forth. Finally, you can also start to look at the local culture. What is the workload for the emergency physician, the degree of fatigue, degree of support that there exists in the emergency department, where and how interruptions occur. What is the local culture on handovers? What is the local culture about complaints and litigation? What is the local culture with their colleagues in other services and consultants, and so on and so forth? So when looking at the diagnostic reasoning processes of the individual clinician, it becomes important to look at wider system factors to be able to target them, to try to optimize them, knowing that this will also improve the diagnostic reasoning process. So this was just a bit of context to frame the discussion today with our speaker panel, and how we want to focus on the role of systems thinking to improve the diagnostic reasoning process. Now we're going to shift to Dr. Shirley Lee, to describe the top 5 diagnostic issues in emergency medicine practice. And in the background afterwards, we're going to have our volunteer, Mariam Zadeh, who's also our Chief Operating Officer at Hiccups for the Incubator Program, taking questions afterwards for our speaker panel, and we'll be really excited to hearing from you. Thank you very much, and I will hand over to Dr. Lee.
Thanks so much, Dr. Tyler. I'm just going to get our slides loaded up, and we'll carry on with our journey. Just a second here. All right, so great to see everyone. This is the last CAEP Grand Rounds we reformed, the big bang before our annual conference, which I hope to see a few of you at. I'm really pleased to be here to speak with you about common diagnostic errors, improving patient safety in the emergency department. So Ahmed's really set the stage with regards to giving you some idea of why are we talking about this really crucial topic. And I'm sort of here to provide a different lens for you to think about with some data that will help you reflect on the synergy between the two things that we're seeing, the outputs that we see with regards to diagnostic error, and how can we as clinicians actually improve that. As Ahmed mentioned, I still work at the Ottawa Hospital as a emergency physician, as well as, my day job is working as a physician advisor with the Canadian Medical Protective Association. My own disclosure is, again, I am an employee of the CNPA, but other than that, I have no other disclosures to discuss. The learning objectives really for this very short, what we call theory burst, that I want to highlight for you is really a couple things. We want to describe common medical legal risks associated with diagnostic errors. I want to identify the top 5 diagnostic issues we see in emergency medicine here in Canada, and help you to recognize features of your EM practice that might actually impact the accuracy of your diagnoses. Now, when we look at the CMP data with regards to the top 3 emergency medicine medical legal themes that are seen, in order of the most common issues seen based on what we call the percentage of critical factors. The number one thing that comes up for all specialties, actually, not just emergency medicine, is diagnostic issues. This is followed by administrative issues, which account for about a quarter of them, where there may be issues with resources, issues with documentation, not having fail-safe systems or redundancy, or issues with test result follow-up. And then thirdly, communication, which accounts for about 20% of the issues we see with our medical legal files. And just to share with you, I want to take a step back again so we kind of look at this from the larger, broader context. The nature of CMPA case data, when we actually see what we are seeing across the country, what we deal with most of the time actually is advice calls. In fact, we take up to 500 calls a day from physicians across Canada, giving them advice about doctor-patient issues related to their care of patients. This is followed by hospital complaints. We do take a few files on that. And again, they're not as common, but we do have some fairly good data on that. This is followed by college complaints. And again, we have a lot of experience. When you see that depth of knowledge on the right-hand side, we have a lot of knowledge and depth with regards to dealing with college complaints because we are very involved with them with regards to the advice we give our members and the guidance and support along the way. And of course, our greatest depth of knowledge is probably with our civil legal cases. However, what I do want to also remind you is that actually is probably the least common type of cases that we see as you look at the bottom graph, in that we have lots of depth about them because the cases do go on for quite a long time and do have quite a bit of detail attached to them, but they're not as frequent. What we'd like to see and shine the light on actually is the information that we can obtain from our advice calls, where we know our depth of knowledge is not as significant, and we see an opportunity there to actually look at the data to actually come up with better frameworks for understanding diagnostic errors that occur. So when we look at the context of emergency medicine as compared to other specialties, yes, we are considered rather high risk. From a medical legal perspective, we are at high risk for being named in a medical legal case. And whether that's due to the patient population that we see, or we also don't really have strong doctor-patient relationships with our patients, but we do have a high risk for being named. That being said, though, and when we are named in a case, many of our cases are very defensible with regards to the care that we try to give our patients the best care we can. However, when there is a medical legal case, though, we have a moderate risk as emerged physicians for an unfavorable medical legal outcome for the member, which means that when the case goes to regulatory bodies or to the courts, there is a more than higher average that the case may not be settled on our behalf with regards to in our favor. And really that's because there is actually quite a significant risk for cases with severe patient harm in our specialty compared to other specialties. So it's all sort of interrelated. And, what I think the take home point I really want to make is not that, oh, great, I'm at more risk of having medical legal action, but when that happens, though, how can I mitigate harm happening to my patients, and really improve my diagnostic, abilities? I also want to highlight also some CNPA themes that we have seen in our diagnostic error cases, specifically for emergency medicine. Now, when we have looked at our analysis, we recently reviewed 5 years of our closed legal cases where we did a sub-analysis of the cases involving diagnostic error and the data that was revealed in the cases where there was a diagnostic issue. Again, in these types of specific situations where there was a diagnostic concern, as I mentioned before, 78% had an unfavorable outcome for emergency physician that was involved, or more than one, and 54% involved a misdiagnosis, where there was an erroneous or a misdiagnosis. And of those cases, again, more than half, or just about half of the cases of the patient suffers severe harm or death. So when we look at this, I want you to think about what you think, and we all have our, our experiences in working to emerge. What do you think are some of the more commonly misdiagnosed clinical conditions in emergency medicine? You can jot them on a piece of paper. I just want to kind of things that pop into your mind, because there are some things that probably are more common than others as far as being misdiagnosed, and certainly gets drilled into us in our residency, or we unfortunately do sometimes learn from our experiences as well. All right, so I give you a chance to think about that, and I'm just going to share with you. So when we think about the most frequent patient presenting conditions that show up in the medical legal case files of the CNPA, these are sort of the top 5 categories and for emergency physicians. Now, I do want to preface this by saying that the frequency of the conditions that we see here is consistent with the practice patterns of emergency medicine, i.e. we just happen to see a lot of people with injuries, infections, and things like that. So it doesn't necessarily reflect that these are high-risk areas, but these are the most frequent things where we're seeing diagnostic issues. So what do I mean by injuries? So when we talk about injuries, this accounts for just under 40% of the cases we see. And these are really the missed tendon injuries, foreign bodies, fractures of the foot, ankle, or radius. You would think we wouldn't miss those because of our access to radiology. But again, these could be secondary injuries and the multi-trauma, but they still come up more often than you think. With infectious issues, it accounts for about 25% of our cases. And what I mean specifically for that is really to deal with sepsis still. Again, the elderly patient that doesn't have a high fever, who might have slightly abnormal vitals, to think about things like sepsis early in your differential, because they may present atypically, or someone who is severely immunocompromised on immunosuppressants may not present with your usual sepsis picture. Meningitis, of course, and necrotizing fasciitis are on that list as well with infectious things. Next, I'm going to move to cardiology. And cardiology actually still comes up. You think in our day and age, so many cardiac studies that we do and all the tests that we have, but again, it's the atypical ones, right? It's the young person that you may not think is having an MI. And again, we need to do that risk stratification, or the elderly, again, female who may present very typically with a myocardial infarction, as well as dissections and AAAs. The last two I want to talk about a bit is really about 10% time we do see issues related to GI with regards to misdiagnoses, whether it's ischemic bowel or those kinds of things, or atypical presentations. And the lastly, neurologic is one, again, about 10%, where those are the subtle atypical presentations which actually end up being TIAs or strokes. And I know we're so used to calling code strokes, but they're atypical presentations. And again, a patient who may not be your typical patient to think they might have a subarachnoid hemorrhage, like they might have injured their head a month ago, not have a loss of consciousness and present just with headaches. So again, widening that differential. And including neurological conditions, I also want to mention spine conditions. So what I mean by that are really things like epidural abscess, to have a high suspicion, perhaps in an individual who might be on intravenous drugs, or that could have an abscess for other reasons in their epidural space, cauda equina, and of course mets to the spine and tumor. So I know that's a lot, that's quite a mouthful, but I probably haven't surprised you really when you think about, these are the things that get missed. And why is it they're getting missed? That's the important part, right? So not just have a that you're going to be on the hunt looking for these things, but really think about what causes us to miss these things, perhaps in the context of individual, team, or system factors. So when we actually looked at the data of our cases with regards to those top contributing factor themes that we saw, there's really 5 that kind of stand out or rose to the top. And the first one really to think about really is, and it comes up again, actually in our general data, not just for emergency medicine, is really deficient assessments. So an inadequate history or physical examination accounted for a very large portion of the diagnostic error cases we saw. And so that really makes you have to think about what parts of the history, right, do I need to make sure I add to the right type of patient that I'm seeing that may have one of those more typical findings. The second thing is really also about that loss of situational awareness, right? So again, having that awareness of the context of making sure you read the triage note, making sure you read the paramedics note, which may be completely different than how the patient looks to you at the time you see them. Or again, there are other contexts going on that may be missed in relationship to that patient's presentation. When we think about deficiencies in monitoring, this is one that's very much always looked at in the courts with regards to either insufficient monitoring or patients not being reassessed for their vital signs, and they've been in the department, let's say, for 8 or 12 hours, and they may have had a significant blood loss. So again, we need to make sure that we are doing our vitals on a timely basis when required in the right patient, because that's certainly something looked upon by the courts as a hard fact that you would consider in the reassessment for a patient who may be hemodynamically unstable. Failure to secure appropriate follow-up. So this one is really interesting because this is really relating to not referring a patient when they actually need a referral, or getting a second opinion, or refer them to an outpatient clinic when it's appropriate. And as well with that part goes hand in hand with unsafe disposition decisions. So an inadequate discharge process does account for some of our top contributing factor themes. And as well, hand in hand with those two probably is a breakdown in communication with the patients, as well as inadequate documentation. So I would like to encourage you to think about, when would you need to kind of fine tune or press those edges on certain cases that we see? And I'm going to talk a bit more about that when you think about where can I actually fine tune my way of diagnosing patients. This is a graph just to demonstrate when we analyze the contributing factors for diagnostic issues in eMERGE. You can see really that there are several issues, but the top ones that are in the purple there, those are the most prevalent related to individual factors where there was issues such as an inadequate clinical assessment or that deficient investigation, or perhaps that premature discharge. Team issues in green and system issues in blue really featured a lot less in our cases, but it may also because we didn't have adequate information at the time when we analyzed our case data, and that's something we're working on to refine our data collection process. All right, so just coming up to the close here of my presentation. So I just want to review in cases where there were severe patient harm, and we use the contributing factors framework for diagnostic error. That's where we've reviewed some of the provider factors, team factors, which are usually about communication and documentation, particularly related to continuity care, featured prominently, those system issues with regards to resources and patient factors. So again, patients that are a bit older, they may have had cardiovascular disease or infection or metabolic illnesses. Make sure to have that heightened sense of awareness related to that. And of course, these can be interrelated. As I showed previously with our some of the data I shared, there can be more than one contributing factor to the same case. So as I come to the key takeaways, that I really want you to think about, I'm going to ask you some questions to kind of reflect on your practice. So have you considered clinical care pathways, practice guidelines, and decision tools that may apply? And sort of to slow yourself down when your patient is not having the typical improvement you would expect with your usual assessment or treatment plan. Pause and reflect on the differential diagnosis, right? And whether you've actually carefully considered any life-threatening possibilities, because it actually is actually a demonstration of your rationale as a physician with regards to your clinical reasoning and your decisions with regards to follow guidelines or not. And the fact that you've even considered them and may have not used them or decide not to do a test is okay, but demonstrating your rationale for your decision-making is really quite important as an emergency physician, particularly when we write diagnoses like headache NYD or chest pain NYD or abdomen pain NYD. Pause and say, well, how am I going to make sure that if I'm going to send someone home with that diagnosis, that they know when to come back should they get more ill. So a couple more things I just want to mention, because diagnosis is actually, it's multi-complex with regards to what improves your diagnostic acumen. And certainly one part of it from my perspective or our perspective at the CMPA is, does your documentation accurately reflect your assessment? And I'll tell you, it's hard to defend when not much is documented on a chart, even though you may have done all of those wonderful things for your patient. Does your documentation support your diagnosis and rationale for your treatment plan? And have you provided those patients and their families members with the appropriate follow-up and clear instructions, including those signs and symptoms of when to return for reassessment? Particularly as soon as I write headache NYD, I'm making sure to really ironclad those follow-up and clear instructions so they know when to come back, because I know there is some uncertainty. I might even mention some of the diagnoses I'm more concerned about if it's appropriate and why we're not pursuing them at this time, and reasons they would need to come back with the appropriate time frame to think about. All right, so I'm going to stop there. I just want to thank you so much for all being here as our audience tonight. We're really looking forward to being with you as the panel. Hi, Ahmed.
All right, thank you so much for this presentation, Dr. Lee, and for everyone who's joining us today. We're going to open up the panel, and we are open to your questions to receive them at any time. But to get things started, I do have a question for our panelists that really it's how to take the knowledge that we have into more practical approach for our clinicians. So, we've discussed some system factors, and when we talk about system factors, historically, they've been seen integral to the patient safety events or a medical error when it occurs. And there's a hierarchy of effectiveness that we can use. But really now we're talking about this internal process, this diagnostic reasoning process. So how do we go a step further and identify these system factors, and what can we do to be able to intervene with this knowledge? And I'll open this up, and I'll ask Lucas to start us off, if that's okay, Dr. Sharti.
Certainly okay, Dr. Daher. Thanks for presenting the theory earlier. I think it's really helpful to put it in context and to be reminded that on top of System 1, System 2, ultimately Gestalt and what happens in a moment is what's going to determine the outcome. We don't often think about System 1 and System 2, perhaps not as often as we need, but I think it's really important to be aware of it. And Shirley, thanks obviously for giving us the practical reality of what happens on the back end or after the care is provided. I think, Ahmed, what you were saying about the hierarchy of effectiveness is applicable for interventions at a system level. That's why we teach and we do in quality improvement all the time. But I think there's something equivalent in our own practice from a diagnostic reasoning perspective. Now, it's not going to match one-to-one, but the reality is that if we rely on our fallible memory and biases, we're not going to get very far. And certainly, as we know, knowledge of cognitive biases may be helpful, although our colleague Jonathan would tell us that perhaps it may not be as useful as others have sold it to us. Jonathan Sherbino, of course, I'm referring to. And so I think what we need to do is elevate our thinking and our practice and to bake it into the practice that we want to have. Now, that could be a cognitive forcing strategy, but that's likely to fail. That can be a checklist, but you need to use it. That can be an order set, but it needs to be evidence-based. I think where we really need to think is that all of these aids and all of the support that we've developed over time have often not been user friendly. That's why people don't like them. That's why we don't use them. That's why we revert to Gestalt. And there's many studies that tell us the Gestalt is just as good. The reality is that it may be good at the aggregate, but at the individual level, this is where the biases in our subconscious is going to seep in. And this is where we're going to miss things. So I think we do need to build the same hierarchy of, I'm going to call it thinking effectiveness. I'm coming up with that term right now, so don't quote me on it. But the reality is that we need to elevate our thinking and our game individually and collectively to be able to not only rely on our brains, because we know they're not going to be good enough. Maybe I'll stop here. I know my colleagues will have many other ways to dissect that question, so I'm looking forward to hearing them.
May I open the floor to Sandra, please?
All right. Thank you. Thank you for inviting me to participate in this panel. And it's been really interesting learning about some of the documented errors and some of the investigations and what they've led to. So thank you for that summary, Dr. Lee. I think I'm going to just state up front the place that I'm coming from. So I'm a cognitive psychologist by training. And so, you know, everything that I think about in this domain in terms of what can help, you know, I take it from the point of view of what can a single person, that single brain, really, what do you have control over? And I've been trying to think of sort of a visual metaphor to describe or to better express what I see as a challenge when people propose things like cognitive forcing strategies. And to me, it's sort of like, you know, you try to sit yourself down at the corner of Yonge and Dundas in the middle of a thunderstorm and meditate. Like I just, you know, and you try to engage in some metacognitive awareness and center yourself so that you can understand what's going on in your mind and order your thoughts. And not that an emergency department is exactly like Yonge and Dundas in a thunderstorm, but I've never worked in a clinical setting at all. But it'd be quite impossible to really achieve that moment of Zen. And we don't, and human beings really don't have that ability to identify where our thoughts are coming from, where our ideas are coming from. You could have influences on your ideas from 10 years ago, from 5 minutes ago. In terms of the way that our memory is constructed, there's no difference in that time frame. And so the things that influence your decisions and the reasons that you might think that, you know, it's an MI or, that, you know, the reasons you might think that you should image in this case and maybe not in another case, those reasons are coming forth to your consciousness, but the subconscious processes are completely unavailable to us. So in terms of what can a system or a systems level approach do to help address those issues, I think it's about, trying to eliminate the thunderstorm, trying to get information organized for the clinician in a way that's maybe less chaotic, and trying to take on some of those challenges. So, for example, again, never having worked in a hospital or emergency department of any kind, but electronic health records are a very, very sore point and can be just a very messy source of information. The studies that I conduct that investigate effective clinical or diagnostic reasoning really are very, very clean and controlled. Our participants sit down in a very quiet setting in front of a computer. Some of you out there may have even been participants in studies that you were recruited for, where Jonathan's reached out to his massive network of friends. And then, you've got everything on the screen. We've carefully placed an image. We have a very brief synopsis of the test result, the patient's primary complaint, and then we're like, give us a diagnosis. I wonder if real clinical practice was like that, what the outcomes might be like in terms of patient experience. So it's really hard to generalize from some of those studies. But I will stop talking there for that moment and pass the mic on to one of my colleagues.
Thank you so much for this great insight. Sean, would love to hear your thinking, please.
Yeah, I mean, really briefly, as you can all see, I think there's a really active sparring match that's taking place in the academic literature around whether or not you can actually cognitively de-bias yourself. There's this group of people that think that if you know the mistake and you know that the lapses, that you can probably course correct. And there's a group of other folks that say you can be as well-intentioned as possible, and that's just not what's going to happen. I'm not smart enough to opine on that specific question, to be totally frank, and that's not going to be a surprise to many of you. That being said, where I think there is a lot of value actually is to spend some time looking at your systems that are picking up data around critical incidents to start, and think about what the system has contributed to that. And I don't mean like ask the people around that were there and say, what do you think the system factors are? Because I think that's flawed. But a very simple thing that we're trying to institute locally is to say, well, is it possible for our EMR to take snapshots of what's happening in the department every 5 minutes? To look at how many beds are occupied, what the queue was in diagnostic imaging, what the nursing assignments were, what the queue was to get to the ward, so that we can have a much better understanding actually of what's happening in our department during these eras. Because I find one of the recommendations we make aren't based on the clinical circumstance in which they occurred oftentimes, but two, don't allow us to have really deep thoughts about the system as we think about changing them. And I would say that overall, like if we're talking about changing things in a meaningful sense, we need to have the data that tells us, not retrospectively, but looking forward, and true learnings from what happened in the past to say, this is how we need to change things. And if I had one change to make to all of our systems, it would be that we have more robust data around incidents.
Thank you so much, Sean. And Shirley, please.
Thanks so much. And Dr. Mondu, you've got me very intrigued with your last comments there about, I just love that idea of having more situational awareness in context that's real data versus just a spider sense or that kind of thing. I'm going to take a little different approach here. We've been talking a lot about systems factors. And what came to my mind, Dr. Tahir, when you asked this question, I really actually was thinking more about the appreciation of, yes, system factors influence our decision-making as clinicians, but I actually wonder how we might consider, how do we create opportunities to shift our perspectives? Kind of along the lines of what Dr. Monteiro was saying, really to better address those diagnostic errors. And is it possible to apply a systems thinking approach, particularly as it applies to the complex environment we work in as emerged physicians, regarding that diagnostic process and error, that we can explore the role of these concepts for systematic thinking. So I will just kind of throw some, themes to think about, with how we think about approaching diagnostic error, where we might actually think about things such as where might I have sub-optimization occurring in my emergency room environment, with my process, what's the emergence with regards to behaviors that can actually be triggered by very small changes in what's happening. Like when I come onto an overnight shift versus a shift during the day and the time of the day, we know those contexts completely change how we practice sometimes and how I address the type of patient populations I'm expecting on that shift. There's also the concept of systems thinking of fractals, right? And how can you actually take a small component of a system or data, sort of like what Dr. Mondu was talking about, to reveal information relating to the bigger things, bigger system as a whole, right? To understand how we process and where are the potentials for improvement, where we can actually tighten things up a bit using those guides to help us practice better. So it's not all just in my head. The last point I'll make is kind of going back to what Dr. Chartier was talking really about. It's really actually about those leverage points, right? So where's that tension we're seeing right now in this, yes, we're trying to figure out the best way to improve our diagnostic processes. And I don't think it's one answer. I think it's going to be many, right? And where that tension is, how can we actually look at those assumptions or unconscious biases as a result of that system context that actually may be holding us back from our ability to actually learn really well from our mistakes so they don't happen again. So I'll stop there.
Thank you so much for these. I think what I'm reflecting on as part of these, just thinking about sort of the patient safety approach, and that a big part of the approach can be preventative, and how when medical error occurs, it may have gone through several different factors that align to end up causing this error. And I think that one of these, maybe at the end of the process, is that decision-making point. And so many things can lead to and affect the decision-making process being non-optimized. And these were some of the factors that we can consider from a systems perspective. Just reflecting also on something else, Dr. Lee, so the 5 themes that you mentioned, including deficient assessment, loss of situational awareness, deficiencies in monitoring, and failure to secure appropriate follow-up and unsafe disposition planning. So when so how do we look at these from a systems perspective? And so what can we do in our emergency department to be able to optimize some of these things, so we can take it back to our team and to be able to start working on this in our next business meeting or our next shift, because we're all very proactive people here. I'll start with Dr. Chamboudou. Let's hear your thoughts, and then we'll go from there.
Yeah, it's a good question, and I don't think for me it falls far from my previous answer. Like, I think we really need to meaningfully look at the kind of errors we're locally running into in those specific spaces, the patient populations, the times of day, the condition in the department that leads to these things, because it shouldn't be surprised that it's going to illuminate things, right? We're going to recognize that either at specific times we don't have enough staffing on the floor, or that our DIQs contribute to this. And those are precisely the data-driven pearls that our hospitals and systems are looking for to drive change. We just almost never have them more than anecdote. And so, that this has been the single biggest frustrating thing for me is to quantify the things we all know to be true, and occasionally to be very wrong in that assumption, which is humbling and very clear. But I think it's something we have to go after. If we're not building systems that can tell us that, or that at least start by understanding it, we can never build the system that tells us when we're getting into a dangerous situation, because we don't know the factors. We can't do that. And like, my head goes like to these crazy AI solutions, right? Dr. Mondu, you're making a decision that breaks from your typical practice pattern. Is that something you meant to do? Like, what a powerful thing. Now, most people, they'd be groaning and be like, oh, another cue from my EMR that I'm doing something daft. But the point is that looking to understand those processes as a system has to be the first step. Like, we can't be meditating or trying to walk to Yonge and Dundas in the dark. Like we can't do that, right? We need data that drives us to those places. And so without that, I think we have no hope. Well, that's maybe too dark. We have little hope.
But there's hope for change. That's why we're having these discussions. All right. Sandra Montero, please.
Thank you. Yes. Yes, I agree. We need some hope. to continue. But I think, so for answering your question, one of the most challenging things that I read when I look at retrospective reports or even summaries like Dr. Lee presented today, is that, it sort of tends to be summed up in one of two ways. You should have known, and that was preventable. And I find that sort of very challenging cognitively, because how can I now say you should have known? How can I now say that was totally preventable? Because I have no ability to simulate the events of that night, or the events of the week's event, like the prior week that led up to a bunch of things going wrong, perhaps. And so I'm kind of like pulling on the thread of we need more data that Sean has pulled out here to say we can only tell the story as well as the documentation that we have. So I think I'm agreeing with Dr. Lee that needs to be better. At the same on the same note, though, even with that, that comes across as you should have known, or you could have done better, or it's preventable, because how can we say that there was enough training for how to do proper documentation? How can we say that there was enough time to actually sit down and write down the important details? How can we say that actually the important information was shared verbally and there was an understanding that everyone got the message, it just wasn't written down, right? So then the written history of that event is in different pieces and all over the place. And so right now, our appreciation of what led to diagnostic errors, right now, the narratives that describe the rates of diagnostic errors, like, not just in Canada, like anywhere really, the history books that have led to those summaries and like stories of how those errors came about and the reasons for them are incomplete. And so we are applying our own interpretation for what the doctors should have known and what could have made it preventable. And some of my colleagues have been looking into this and sort of exploring the gap between knowing and doing. And I've come across multiple situations where the assumption is they were taught this in residency, or they were taught this, at whatever event. They should have known, they should have followed through. But there's a myriad of reasons why that doesn't happen. And I'm sure we all even experience that in our daily lives. There's lots of things we should be doing. There's lots of things we know are good for us, and we still don't do them. And it's no different for clinicians, especially in a busy work environment. So you should wash your hands. That's good practice. And everyone will recite that they absolutely know that. And there are still inconsistencies in people following through with that. That antibiotics are not good for viral infections, and yet there's still not consistency in terms of following through with that. And sometimes it's the pressures of the patient. And so I've been part of multiple conversations where clinician educators are really, really passionate about a particular guideline, and they say, my colleagues know this. I believe they need more education to make sure they stick to those guidelines. But when I say, well, let's just ask them, and it's always everything but. They absolutely know the guidelines verbatim. They just refuse to follow them because the situation doesn't call for it. So more data, I think, is definitely a great way to get us closer to some solutions.
Thank you so much. And Dr. Lee.
Yeah, thanks. So I'm really glad Dr. Montero brought up those perspectives with regards to, there's things like hindsight bias, obviously, right? We can all see that after a bad outcome occurs, so we go to M&M rounds with regards to, if they'd only done or saw those retroscopes, they would have understood those better. What I want to reassure physicians first, I think it's really important, because we are focusing on how to improve your diagnostic processes or issues, is that I will share with you that from a medical legal perspective, the courts and the colleges actually are not expecting us to be perfect. Thank God, right? They do not expect us to be perfect. What they do expect is that there is reasonableness with the care we provide that would meet the standard of what you, I, or someone else practicing emergency medicine would give to a patient who presents with a set of symptoms. I think so I want to reassure people that this is not about being perfect, because if you think that coming out of this talk, all or nothing thinking, that is not going to be of any help to any of you. I also want to make the point that certainly our data is not meant to at all sound like the physician should have done this, or they've made a terrible error, so it must be a terrible physician. That is not the case at all. The point of the data, what we have this time, which is not the best data, absolutely, I think there could be much better data that we can get more granular with, is to at least give us some direction to what we're seeing as the common themes. And even though I did mention a number of contributing factors attributed with different percentages, we can't be hitting everything with the same amount of force with regards to this is where I'm spending all my efforts. When I think about that systems approach, with regards to how am I going to make myself better in my diagnostic processes, and small changes, right, are where we should start. One thing I'd really encourage physicians to really think about, okay, we're really good at that first part because we all want to get the answer. We all want to know what the diagnosis is. We're like Columbo or whatever detective show you'd like. And once we got the diagnosis, it's like the magic door opens and you know everything to do and it just feels so good, right? Versus some other types of diagnosis really make us struggle because even if you get the right diagnosis, you're still struggling with the patient. So I'm encouraging you to actually think more about the latter 50% of the time you spend with your patients with regards to those things I talked about, with regards to have I ordered all the tests? Is my patient actually improving with the standard treatment that I use for migraine, or is there something else going on? And I'm sending them home, I'm sending them home as an NYD. So do I have the appropriate follow-up? Do I have that safe discharge planning? Because that's where we see the effort fall off, compared to the first half with the diagnostic process. I don't want to sound like a broken record, but I have to agree with Dr. Mondu and Dr. Montero about data. I really am a big believer with regards to that role in us being able to improve the diagnosis process as a profession, and that the importance of big data to elucidate those themes nationally is going to be an important strategy to help shine the light on trends that are observed in that process on a larger scale versus one-offs. And certainly our organization, as well as other organizations, are collaborating with each other on a national level with databases, looking at patient safety data to define exactly what this looks like at systems level to improve that diagnostic process and what we know about the science of diagnostic reasoning, which is quite complex. I'll stop there.
Thank you so much for your thoughts. I'll open to the floor to Lucas, please.
So I agree with all the points being made by my colleagues, and at the risk of being redundant, I just want to pull a few of them together. It's always reassuring to hear from the CMPA and other leading authorities that we don't need to be perfect. And certainly NYD is an acronym that I use quite a bit, so I'm going to need to certainly pay attention to that. But I think while we don't need to be perfect, I sometimes fear that in these cases, we are compared to a reasonable physician working in a similar context, and that's the level at which we are subjected to. But the reality is that that same physician, be it me or anyone on the call, is not going to work at the same level within the same context, depending on the day of the week and the hour of the week and the busy nature of the department. And so I think this is where we really need to dig a little bit deeper. And you've all mentioned data, and I completely agree. I feel like we're all of us walking to Dundas Square with a flashlight and trying to figure out what's going on. We need the big billboard to be on. We need the day to be on. We need the real light to be turned on so that we can actually see everything. And this is where I think innovative ideas like what Sean was describing earlier, which is to take a snapshot of your department to be able to understand what was happening. And that doesn't have to be for medical legal purposes. Just from a patient safety purpose and improvement purpose, this is where we need to start thinking about this. And there's so much data, and many have been mentioned in terms of the department and the wait time and the crowding of the waiting room, those are all things that actually make a huge difference. We all know that when you walk in for your overnight shift through that waiting room and it's bustling at the seams, you know your heart rate is going up by 5 or 10 beats per minute, and you're probably not making the best decisions, right, because of that entryway. And so we really need to be cognizant of that. And without the data, we won't be able to do it. And I really like what Sandra said about washing hands. We all know it's important. Well, it's funny that it took a global pandemic for us to actually start doing it, right? Because then it started mattering for us. So I think we really need to, it's unfortunate, but it's true. We need to think about what is it for us so that we can reach the people. I don't mean this in a selfish way because providers only care about themselves. I only mean that our incentives and our alignment have never been right. And so this is where we need to figure out how we're going to tackle it. Maybe I'll stop here, Ahmed. I'm sure you have some follow-up questions or thoughts.
No, this is great. I'm just trying to open it up to our viewers as well. We do have a couple of questions, but one comment to your question was about the role of scribes to assist physicians as part of this data gathering. Any thoughts from our panel on this?
If I can jump in, I would be in support of that. If there's, a budget to support that, you talk about cognitive offloading, like that is a perfect example of that. Someone would need to be trained to know what the important information is that needs to be documented and who to share that with. But that could be a potential new health profession's role. It doesn't take away the need for the clinician to spend a moment and documenting things in some way, like to kind of download their thoughts and reflect on it. I think there's still an important place for that action and that moment of thinking about the patient, and documentation helps you to do that reflection. But for example, you're running from patient to patient, and it's possible you might forget whether it's the left or the right that needs to be imaged, or you forget that patient A needs their chest imaged and patient B needs their legs x-rayed. So, those things are common human mistakes that can occur just because you're trying to keep it all in place.
All right, I do think we have a couple more questions, but I'm cognizant of the time. I just wanted to wrap it up with one summative question. For everyone who's viewing, for our clinicians who view this, what's one thing that each of our panelists think that they can take away from today's talk on their next shift or in their next meeting with their group to be able to advance this agenda of trying to improve diagnostic reasoning really by looking at their system? If I may start with Dr. Lee, please.
My plea is to be a mythbuster and really recommend people to write out the differential diagnosis. I know this is one that a lot of physicians don't want to do. They believe it puts them at risk. But if anything, it helps with outlining your cognitive process to think of those alternative diagnoses and really slowing yourself down.
All right, and Dr. Chartier, please.
I'm going to go totally off script here and say, be kind to yourself. I mean, we're discussing about how much, I know, crazy. We're discussing how much the context in the system will change our decision-making. And we're so hard on ourselves. And things will happen. And especially after 2 years of crazy world, just be kind to yourself, because there's nothing you can do to be perfect, as we've heard. Things are going to happen. So let's just accept it, and let's use all of the other solutions my colleagues are going to tell you to prevent that. But if it does happen, just be kind to yourself.
Dr. Monteiro.
Well, thank you. Dr. Chartier took my comment, so I will add to it. Which is, when mistakes happen, yes, be kind to yourself. But I think we don't spend enough time learning from them. There's a lot of auditing and then trying to correct them. And some of those cognitive forcing strategies are about trying to prevent a mistake in the moment and in the future. And so I'd suggest, if there's time, think about what happened last week, yesterday, and mistakes or positive outcomes, whichever. Reflect on them and learn from them.
And Dr. Mandu.
I would say that as a clinician, you shouldn't let the narrative of what happens in the department be the reality of what has taken place. I think we all owe it to ourselves in an act of kindness, in an act of improvement, in an act of investment, to ask about getting real objective data about what's happening in our space. And use that to obviously be nice and kind and improve ourselves, but also to be citizens of the system and try to help make it better. So don't tolerate the narrative being what happened. You know, ask for a little bit better. I think we can get that. I think it's so close.
I just wanted to thank everyone again for joining us today at these CAEP Grand Rounds. I wanted to say thank you to each and every one of our panelists for sharing their time and their expertise. Thank you to the CAEP productions team for organizing and for facilitating, and to our volunteer, Miriam Zadeh, as well, for taking the questions down. Please, there are lots of opportunities to implement change, implement positive change, and look at opportunities at the system level, not just at the individual level. So lots to think about. Happy to take questions offline as well. And thank you so much all for joining us, and hope everyone has a wonderful day.